Welcome to the deep dive. Today, we're taking a really interesting journey into how our bodies react when things go wrong. Injury, disease.
Yeah, we're looking at the defense systems, the repair mechanisms that, well, that kick in.
And for this, we're drawing on medical exam blueprints, the ones covering pathophysiology.
Right. So think of it like getting a look under the hood, really seeing how these response systems work.
Exactly. And our mission here really is to pull out the core ideas, how we defend ourselves, how we heal from that very first alarm bell right through to, the complex stuff involving blood, brain, lungs.
And showing how it's all connected,
Yeah.
because it really is. And of course, what happens when these systems go off track?
Yeah, and we want to do this in a way that's clear, engaging, without getting bogged down in super technical jargon. Okay,
Sounds good. So where do we start?
let's kick off with the body's first responders, inflammation and wound healing.
Right. And the first thing to grasp about inflammation, which sometimes gets a bad rap, is that fundamentally it's a repair process.
Yeah, I always remember that lightitis ending on medical terms.
Exactly. Bronchitis, appendicitis.
It's like the body shouting, hey, problem here.
Pretty much. The basic definition is it's a protective, coordinated response to some kind of injury or insult.
And we've all felt those key signs, right? The 5 cardinal signs.
Oh, yeah. You get the heat and the redness that's from increased blood flow rushing to the site.
Okay.
Then there's swelling. That happens because fluid, this protein-rich stuff called exudate, leaks out of the blood vessels into the tissues.
Makes sense. And pain, obviously.
Pain, definitely. And sometimes loss of function, often just because the tissue is injured or swollen.
No, inflammation isn't always quick, is it? Sometimes it sticks around. What's the deal there?
That's the crucial difference between acute and chronic inflammation. Acute is the immediate short-term thing. Very local.
Like a sprained ankle.
Exactly.
Yeah.
It involves specific white blood cells, granulocytes, monocytes showing up fast. The goal: get rid of the bad stuff, limit damage, start fixing. Quick in, quick out, ideally.
But chronic.
Chronic is different. It's persistent, often more subtle, can last weeks, months, even years. Different cells are involved here, mainly lymphocytes and macrophages.
And that's not good.
Well, the problem is chronic inflammation itself can cause ongoing tissue destruction. It's often a precursor or a contributing factor to many long-term diseases, heart disease, arthritis, things like that. So acute is the repair crew. Chronic can become, well, destructive if it doesn't resolve.
Okay, so focusing on acute inflammation, it happens in stages, like a sequence.
Yeah, pretty much. First up is the vascular phase. It starts with a brief tightening of the blood vessels, vasoconstriction, but almost immediately followed by vasodilation, they widen up.
Okay.
And they get more permeable, more leaky. This is driven by chemical signals like histamine and nitric oxide.
Why leaky?
So that fluid, the exudate we mentioned, can get out into the tissues, bringing proteins and leading to that swelling, the edema. It'll dilute toxins and brings important stuff to the area.
Got it. So the pipes widen and leak. Then what?
Then come the cells. That's the cellular phase. The main goal here is getting neutrophils, a key type of white blood cell, delivered to the site.
The reinforcements arrive.
Exactly. It's a multi-step process. First, they have to stick to the inside walls of the blood vessels, that's adhesion.
Okay.
Then they literally squeeze themselves out between the cells of the vessel wall. That's transmigration.
Wow.
And finally, they follow chemical trails, like breadcrumbs, towards the injury site. That's chemotaxis.
So they know exactly where to go.
Right. And once they get there, these neutrophils, along with the macrophages that arise a bit later, start engulfing and destroying bacteria, debris, whatever shouldn't be there. Yeah. That's phagocytosis, basically, cell eating.
It sounds incredibly coordinated. You mentioned chemical signals like histamine. These are the mediators.
Yes, the mediators are crucial. They initiate the whole thing and keep it going. They cause the vasodilation and permeability we talked about.
Okay.
They also act like signal flares, recruiting more white blood cells. Some mediators trigger pain receptors, your body's alarm system, and others help with blood clotting.
Where do they come from?
2 main sources. Some are plasma-derived, made mainly in the liver and circulating in the blood in an inactive form, ready to go. Think of the complement system, the Cannin system, the clotting factors.
Like pre-packaged emergency kits.
Sort of, yeah. Others are cell-derived, released from cells right at the site of injury or inflammation. Histamine is a big one here, stored in mast cells.
Ah, histamine. We hear about that with allergies all the time.
Exactly. It's one of the first responders, released really quickly. When IgE antibodies bind to mast cells, poof, histamine comes out. It causes that vasodilation, the leakiness, and that itching sensation, pruritus.
Right.
In severe reactions, like anaphylaxis, it can cause a big drop in blood pressure or even fluid in the lungs, pulmonary edema.
And you mentioned another one, arachidonic acid.
Yeah, arachidonic acid is important because it's like a raw material. It gets converted into other powerful mediators like prostaglandins and leukotrienes, which also drive inflammation.
Okay, so if these mediators drive inflammation, how do drugs like corticosteroids work? Like cortisone shots?
Good question. Corticosteroids work further upstream. They basically block the production of arachidonic acid itself. They stop certain molecules in the cell membrane, phospholipids, from hooking up with an enzyme called phospholipase.
So they cut off the supply.
Exactly.
Right.
No arachidonic acid means fewer prostaglandins and leukotrienes, which dampens the whole inflammatory response.
Okay, so the inflammation has hopefully done its job, dealt with the immediate threat. What about fixing the damage? Tissue repair.
Right, that's the next critical step, restoring the structure and function. The ideal outcome is regeneration,
Meaning?
meaning the damaged cells get replaced by the exact same type of cell. No scar, no lasting injury, back to normal.
But that doesn't always happen.
No, it really depends on the type of cell that was damaged and where the injury is. Some cells regenerate easily, others don't.
And wounds themselves heal differently depending on the cut, right?
Absolutely. We talk about three main types of wound healing. Primary intention is the best case scenario. Think of a clean surgical incision.
For stitches.
Right, where the edges are brought close together, approximated. Minimal tissue loss, minimal scarring. That's the goal.
Okay.
Then there's secondary intention. This happens when there's a bigger gap, more tissue loss, maybe like a large scrape or a pressure ulcer.
So it can't just be stitched closed.
Exactly. The body has to fill that gap in from the bottom up with granulation tissue, that sort of pink, bumpy stuff you see in a healing wound. This eventually matures into fibrous scar tissue. So you always get a scar with secondary intention.
And the third type?
Tertiary intention, sometimes called delayed primary closure. This is for wounds that are large, often contaminated, maybe with debris or infection risk.
Like a really dirty wound.
Yeah. They might leave it open initially to clean it out, maybe pack it, let some initial healing happen, and then close it later, perhaps with stitches or even a skin graft.
It sounds like a lot can interfere with this healing process.
Oh, definitely. Nutrition is huge. You need protein, and specific vitamins A, B, C are vital for making collagen, the main structural protein. Vitamin K for clotting. Zinc for new cell growth.
Makes sense. What else?
Blood flow is critical. You need oxygen and nutrients delivered to the site. So conditions that affect circulation, like peripheral artery disease or diabetes, can really slow healing.
Diabetes is a big one, right?
Yes, because it can damage blood vessels and nerves, plus impair the immune response itself. Infection is another major obstacle.
Obviously.
Wound separation or dehiscence if the edges pull apart. Foreign bodies left in the wound. Even the type of wound animal bites, for instance, have a high infection risk because of bacteria in saliva.
Anything else?
Age matters too. Newborns have immature immune systems. Older adults might have slower cell turnover, reduced collagen, poor circulation, and sometimes weaker immunity. Mobility also plays a role. Being immobile can affect blood flow.
And sometimes the healing itself goes wrong, creates new problems.
Unfortunately, yes. Complications can arise. You can get keloids. That's an overgrowth of scar tissue, raised and often discolored.
I've seen those.
Contractures happen when scar tissue shrinks and tightens, potentially limiting movement, especially over joints.
Ouch.
Dehiscence, as I mentioned, is the wound reopening. Evisceration is even worse, where internal organs actually protrude through an open wound. That's a surgical emergency.
Okay, that's serious.
You can also get strictures, which is an abnormal narrowing of a tube or passage like the esophagus due to scar tissue. Fistulas are abnormal connections forming between two organs or spaces that shouldn't be linked. And adhesions are bands of internal scar tissue that can form between organs after surgery, sometimes causing pain or blockages.
Wow, quite a range of potential issues. Okay, let's shift gears now. Let's talk about the body's defenders against invaders, infection and immunity.
Right. And it's amazing when you think about it. We live with countless microorganisms all the time, our microflora.
Most are harmless or even helpful.
Exactly. E. coli in our gut is a classic example. Totally normal there, helps us digest. But if it gets into the urinary tract, infection, that highlights the difference between our normal microflora and colonization versus actual infection.
So colonization is just having it there.
Pretty much. A potentially harmful microbe is present, maybe on your skin or in your nose, but it's not causing disease. MRSA is a good example. Lots of people carry in their nose, totally unaware, no symptoms.
Until
until there's an opportunity like a break in the skin, a wound, maybe surgery, and then it can invade and cause an infection.
Okay, and the types of microbes that can cause infection are really varied.
Hugely varied. You've got bacteria, single-celled organisms.
Yeah.
We categorize them based on shape and how they stain the gram stain.
Gram-positive, gram-negative.
Right. Gram-positive have thick walls, stain purple. Gram-negative have thinner walls, stain pink. It's a really important first step in identifying bacteria and guiding antibiotic choice. Think strep throat, bacterial pneumonia, TB, whooping cough, all bacterial.
Okay, then viruses.
Viruses are tiny, much smaller. They aren't even really cells, just genetic material, DNA or RNA, inside a protein coat. They have to invade a host cell to replicate.
And they can hide out for a long time.
Yes, they can remain dormant. Herpes viruses, adenovirus, influenza, HPV, which is linked to cervical cancer, those are all viruses. Diagnosis can involve looking for the virus itself, its proteins, its genetic material like with PCR, or the body's antibody response.
What about fungi?
Fungi are more like molds or yeasts. They can cause superficial infections, skin, hair, nails, big athlete's foot. Ringworms, those are caused by dermatophytes, a type of fungi.
Like Tina.
Exactly. Or they can cause systemic infections, getting inside the body. Those are rarer, but can be serious, especially in people with weakened immune systems. Candida albicans, causing thrush, is a common example of a yeast infection. Diagnosis usually involves cultures or microscopy. Parasites. Parasites live off other organisms. They include protozoa, single-celled ones, like the one causing malaria, often spread by vectors like mosquitoes or through contaminated food water causing gut infections. Then there are helminths, worms, and arthropods, like ticks or mites, which can be parasites themselves or vectors carrying other diseases. Diagnosis often involves stool samples or blood smears.
And the last one? Prions. Those sound weird.
They are weird. Prions aren't even alive in the traditional sense. They're misfolded proteins.
But a protein causes infection.
Yeah, it's kind of mind-blowing. This misfolded prion protein somehow induces normal proteins in the brain to misfold in the same way. It's like a chain reaction. It leads to a progressive, fatal degeneration of brain tissue. It becomes sort of spongy. Mad cow disease and its human equivalent, Creutzfeldt-Jakob disease, are prion diseases. Diagnosis is tricky, often involving testing cerebrospinal fluid for the abnormal protein.
Okay, so quite the rogues gallery of potential invaders. Once one gets in, how does an infection typically play out? What are the stages?
Generally, there are 5 stages. First is incubation. The pathogen gets in, starts multiplying, but you don't feel anything yet. No symptoms.
Okay.
Then comes the prodromal stage. This is when you start feeling generally unwell, maybe tired, achy. The first non-specific symptoms appear. Your immune system is ramping up. White blood cell count starts to rise.
I think I might be coming down with something feeling.
Yeah, exactly that feeling. Next is the acute stage. This is when the infection hits its peak. The pathogen is multiplying rapidly, causing tissue damage. Inflammation is pronounced. You feel the sickest during this stage, with specific symptoms of the illness. After the peak, hopefully, comes the convalescent stage. Your immune system starts getting the upper hand, containing the infection, eliminating the pathogen. Tissue repair begins. Symptoms start to subside, become more manageable.
Getting better, but not quite there yet.
Right. And finally, the resolution stage. The pathogen is totally eliminated, damaged tissues are repaired, and you return to full health.
So how do these bugs actually get from point A to point B? How are they transmitted?
The mechanisms of transmission. Several factors are involved. First, the pathogen needs a way in, a portal of entry. Skin, respiratory tract, GI tract, urogenital tract.
Okay.
Then there's the mode of transmission, how it travels to that portal. Could be penetration, like stepping on a rusty nail.
Right.
Direct contact, touching someone infectious. Sexual contact. Ingesting contaminated food or water. Inhalation, breathing in droplets from a cough or sneeze. Blood-to-blood contact, like sharing needles. Or even maternal-fetal transmission during pregnancy or birth.
Where does it come from in the first place? The source?
The source can be endogenous, meaning from your own body's microflora, like that E. coli gut bacteria causing a UTI, or a candida yeast infection after antibiotics disrupt normal flora.
Okay.
Or it can be exogenous from outside your body. The environment, another person, an animal. Fomites are inanimate objects that can harbor pathogens, doorknobs, phones, towels.
Ugh.
And a vector is a living creature that transmits the pathogen. Mosquitoes carrying malaria, ticks carrying Lyme disease.
We can also think about the source as a place, right? Like hospital-acquired infections.
Exactly. Nosocomial infections are those acquired in a healthcare setting, often involving more resistant bacteria. Community-acquired infections are picked up, well, out in the community.
And our own immune response influences this. You mentioned antibody titers.
Yes, the level of antibodies in your blood, the titer tells us about your immune response. IgM antibodies usually pop up first in a new infection, the initial responders. IgG comes later but provides longer-lasting immunity, that immunological memory. IgE, as we said, is more about allergies and parasites.
Okay, let's dive deeper into that immune system itself. You mentioned innate and adaptive.
Right. Two main arms. The innate immune system is your built-in first line of defense. It's rapid but non-specific. It doesn't recognize specific germs, just general danger signals.
As cells are involved?
It all starts in the bone marrow. Key players are phagocytes, the eaters. Think neutrophils, the first ones on the scene for bacteria. Monocytes circulate in blood, then move into tissues and become macrophages, big eaters that also send out signals. And dendritic cells, they're crucial antigen presenters.
Antigen presenters.
They gobble up invaders, chop them into pieces, antigens, and then show those pieces to the adaptive immune system, basically saying, hey, look what I found. We need to deal with a specific threat.
It was a mnemonic.
Oh, right, for some phagocytes. Pneumoles make dinner. Neutrophils. Monocytes, macrophages. Dendritic cells. Helpful, maybe.
Okay. Any other innate cells?
Yep, non-phagocytic ones, too. Eosinophils and basophils deal more with parasites and allergies. Basophils release histamine. Mast cells hang out in tissues and are packed with histamine and other pro-inflammatory stuff. And don't forget the complement system, a set of proteins in the blood that can directly kill pathogens or tag them for phagocytes.
So the innate system is the immediate general response. What about adaptive?
Adaptive immunity is acquired. It develops over your lifetime as you encounter things. It's highly specific targets, particular invaders. And crucially, it has memory.
That's where T cells and B cells come in.
Exactly. Two main branches here. Antibody-mediated, or humoral immunity, involves B lymphocytes. They mature in the bone marrow. When activated, often with help from T helper cells, they turn into plasma cells and pump out antibodies.
What do antibodies do?
Antibodies, or immunoglobulins, circulate in blood and fluids. They're like targeted missiles against pathogens outside of cells, bacteria in the blood, viruses before they infect cells.
And the other branch?
Cell-mediated immunity. This involves T lymphocytes, which mature in the thymus. T cells don't make antibodies. They directly attack cells that are already infected or abnormal, like virus-infected cells or cancer cells.
So B cells handle threats outside cells, T cells handle threats inside cells.
That's a good way to think about it, broadly speaking.
You mentioned different antibody types earlier, IgM, IgG.
Right. IgM is usually the first responder antibody in a new infection. IgE is the main one for long-term immunity, the most abundant, and the only one that crosses the placenta to protect the baby. IgA is found in secretions, mucus, saliva, tears guarding those surfaces. IgE, again, allergies and parasites. IgD's role is a bit less clear, involved in B-cell activation.
Okay. And antigens are the things the antibodies recognize.
Precisely. Antigens are specific molecules, usually proteins, on the surface of pathogens or toxins that the immune system recognizes as foreign. Antibodies are typically Y-shaped proteins made by B cells, and the tips of the Y bind very specifically to an antigen, like a lock and key. This tags the pathogen for destruction.
And we can acquire immunity actively or passively.
Yes. Active immunity is when your body makes the antibodies and memory cells, either because you got sick or you got vaccinated. It's long-lasting.
Okay.
Passive immunity is when you receive pre-made antibodies from somewhere else, like a baby getting antibodies from mom through the placenta or breast milk, or getting an injection of antibodies. It's temporary protection because your body didn't make them itself.
So vaccines give us active immunity.
Correct. Vaccines introduce antigens, maybe weakened or killed pathogens, or just pieces of them to stimulate your immune system to mount a response, make antibodies, and crucially, create memory B and T cells.
So if you encounter the real thing later,
your memory cells recognize it immediately and launch a much faster, stronger secondary response, often preventing you from getting sick at all.
Yeah.
That's why booster shots work. They remind the memory cells, boosting that protection.
But sometimes this powerful system goes haywire. Allergies.
That's hypersensitivity. The immune system overreacts to something usually harmless, an allergen. Four main types. Type 1 is the immediate one. Think classic allergies.
Hay fever, hives.
Exactly. It's IgE mediated. Gets sensitized first. Then on re-exposure, mast cells release histamine rapidly, often genetic. And histamines help symptoms. Can range from mild itching to severe anaphylaxis.
Okay, type 1. What's type 2?
Type 2 is antibody-mediated or cytotoxic. Here, IgG or IgM antibodies mistakenly attack the body's own cells. targeting self-antigens. The complement system often gets activated, leading to cell damage.
Examples.
Graves' disease, where antibodies stimulate the thyroid. Myasthenia gravis, where antibodies block nerve signals to muscles.
Type 3.
Immune complex mediated, little clumps of antigen bound to antibody get deposited in tissues, blood vessels, joints, kidneys, triggering inflammation and damage there. Lupus and rheumatoid arthritis often involve type 3 reactions.
Stem type 4.
Cell-mediated or delayed hypersensitivity. This one's driven by T cells, not antibodies, and takes longer to develop, usually 24 to 72 hours.
Like poison ivy rash.
Perfect example. Contact dermatitis. The T cells react where the allergen touched the skin.
Got it. Now, there's one virus that specifically targets the immune system itself, HIV.
Yes, HIV is devastating because it goes right after the T helper cells, the CD4 cells. These cells are like the conductors of the immune orchestra.
So without them,
The whole adaptive immune response gets severely weakened. This leaves the person vulnerable to opportunistic infections, germs that normally wouldn't cause problems.
and HIV is a retrovirus.
Right. Its genetic material is RNA. It uses an enzyme to make a DNA copy of its RNA, which then gets inserted into the host cell's DNA. That's how it takes over.
How is it transmitted?
Primarily through blood, semen, vaginal secretions, and breast milk. Sexual contact is the most common way. Sharing needles is another major route.
And it progresses in stages?
Generally, yes. First is the acute stage, a few weeks after infection. Can feel like a bad flu. That's acute retroviral syndrome.
Right.
Viral load is very high, but CD4 count is usually still decent, above 500. Then comes clinical latency. This can last for years, often with few or no symptoms. The virus is still active, but reproducing at lower levels. CD4 count gradually drops, maybe from 350, 499, down towards 200.
And the final stage?
AIDS-acquired immunodeficiency syndrome. This isn't a separate virus. It's the stage defined by severe immune damage, usually a CD4 count below 200, or the presence of specific opportunistic infections or cancers. Viral load is typically high again if untreated.
How is it monitored?
Labs. Key tests are the HIV antibody test for screening, HIV RNA PCR measures viral load, detects early infection, and the CD4 cell count measures immune damage. There are also combination antigen-antibody tests for earlier diagnosis and drug resistance testing to guide treatment.
Diagnosis needs confirmation.
Yes, usually a screening test like ELA is confirmed with a more specific test like a Western blot or PCR. CD4 and viral load track the stage and treatment effectiveness.
And those opportunistic infections become a big problem below CD4 200.
Very much so. Things like PCP pneumonia, TB, severe candida infections, thrush, toxoplasmosis become major threats. Medications can manage HIV very effectively now, keeping viral load undetectable and CD4 counts up, but it's still not a cure.
Okay, a lot to unpack there. Let's move into the blood itself. What happens when blood cells misbehave, starting with white blood cells?
Right, leukocytes. Crucial infection fighters. And remember, they all come from that common starting point, the pluripotent stem cell in the bone marrow.
And there are different types, granulocytes and agranulocytes?
Yep, granulocytes lack granules in their cytoplasm. That's lymphocytes, the T and B cells of adaptive immunity, and monocytes. Monocytes circulate briefly, then become macrophages or dendritic cells in the tissues. Macrophages are big eaters and signalers. Dendritic cells are the antigen presenters.
Okay. And granulocytes have the granules.
Correct. Those granules contain various enzymes and chemicals. This group includes neutrophils, the most abundant main bacterial fighters, the first responders.
Also called PMNs.
Right, polymorphonuclear leukocytes, because of their weirdly shaped nucleus. Then there are eosinophils, mainly for parasites and allergies, and basophils, also involved in allergies and inflammation, releasing histamine.
You mentioned neutrophils having different forms. Bands and segs.
Yeah, bands are immature neutrophils. Seeing a lot of them in the blood, a shift to the left means the bone marrow is churning them out rapidly, usually due to an active infection. Segs are mature neutrophils with segmented nuclei.
How do we track these cell counts?
The complete blood count, or CBC, is the main tool. It gives the total white blood cell count. Normal is roughly 5,000, 10,000 per microliter. Leukopenia means a low total count, below 4,000 maybe.
And the CBC usually includes a differential.
Yes. The diff breaks it down, tells you the percentage of each type. Neutrophils, lymphocytes, monocytes, eosinophils, basophils. This gives a much clearer picture of what might be going on.
What about low neutrophils specifically? Neutropenia.
Neutropenia is a neutrophil count below about 1,500. Since they're key for fighting bacteria, this increases infection risks significantly. It can be caused by chemo, other drugs, some diseases. Sometimes medication like filgrastim is given to boost neutrophil production.
And ANC.
Absolute neutrophil count. It's a calculation. Total WBC count multiplied by the percentage of neutrophils, segs plus bands. It gives a precise measure of infection-fighting capacity. Below 1,500 is neutropenic. Below 500 is severe neutropenia requiring strict precautions.
Okay. What about specific disorders involving white cells, like mono?
Right, infectious mononucleosis, often caused by the Epstein-Barr virus, EBV, the Cushing disease. It infects B lymphocytes, causing fever, sore throat, swollen lymph nodes, fatigue. Usually resolves on its own, but fatigue can linger.
And myelodysplastic syndrome, MDS.
MDS is tougher. It's a group of disorders where the bone marrow doesn't make enough healthy blood cells or makes defective ones. So you get low counts anemia, neutropenia, low platelets. It's considered a pre-leukemic condition sometimes.
Which brings us to blood cancers. Hematological neoplasms, lymphoma.
Lymphoma is a cancer of the lymphocytes, B or T cells, that forms solid tumors, usually in lymph nodes, but can be elsewhere. Actually more common than leukemia overall. Two main types, Hodgkin and non-Hodgkin.
Hodgkin.
Hodgkin lymphoma typically involves specific abnormal B cells called Reed-Sternberg cells. Often affects young adults, usually starts in one lymph node group, often painless swelling. Treatment, chemo, radiation, immunotherapy, is often successful. There might be an EBV link sometimes.
Non-Hodgkin.
Non-Hodgkin lymphoma, NHL, is much more diverse. It can arise from B cells, T cells, or NK cells. More common in older adults, many subtypes. Risk factors include chromosome changes, certain infections, immunosuppression, maybe environmental factors. Also presents with enlarged nodes, but can be more widespread.
Diagnosis for both.
CBC with DIF, definitely. Bone marrow biopsy is crucial. Lymph node biopsy is needed to identify the type, maybe a lumbar puncture to check spinal fluid. Treatment is varied. Chemo, radiation, monoclonal antibodies targeting specific cell markers, stem cell transplant, CRT therapy. Lots of options now.
Okay. What about leukemia?
Leukemia is different because it's cancer of the white blood cells, starting in the bone marrow itself. Abnormal precursor cells proliferate wildly, crowding out normal blood cell production. It can be acute, rapid, or chronic, slower. Classified by the type of cell involved, lymphoid or myeloid.
Diagnosis and treatment similar to lymphoma.
Diagnosis involves CBC, bone marrow biopsy, lumbar puncture, yes. Treatment also uses chemo, radiation, targeted therapies like monoclonal antibodies, stem cell transplant, CRT. Depends heavily on the specific type and patient factors.
And multiple myeloma.
Multiple myeloma is a cancer specifically of plasma cells, the mature B cells that make antibodies. These cancerous plasma cells produce a huge amount of a single abnormal antibody, monoclonal protein.
What problems does that cause?
It leads to bone destruction tumors in bones, bone pain, often back pain, risk of fractures, osteopenia. The abnormal proteins can damage kidneys. It crowds out normal marrow, causing anemia and low immunity.
Is there a mnemonic for that one too?
Yes, the CAB criteria help remember key features: calcium elevation, renal dysfunction, anemia, bone disease. Diagnosis usually needs 10% plasma cells in the marrow. Treatment includes chemo, steroids, stem cell transplant, CRT.
Okay, let's switch to red blood cells now. Oxygen carriers.
Right. Erythrocytes, made through hematopoiesis in the bone marrow. Their job relies on hemoglobin, the protein that actually binds oxygen. Hematocrit measures the percentage of blood volume taken up by red cells.
And EPO?
Erythropoietin, hormone mainly from the kidneys. Released when oxygen levels are low, tells the bone marrow to make more red blood cells, a key regulator.
So anemia is basically not enough red cells or hemoglobin.
Exactly. Low RBCs, low hemoglobin, low hematocrit. Any or all of these lead to reduced oxygen carrying capacity. Causes are varied: blood loss, decreased production like iron or B12 deficiency, or increased destruction hemolysis.
Like in sickle cell anemia.
Precisely. Sickle cell is an inherited disorder, autosomal recessive. A gene mutation causes abnormal hemoglobin S, HGBS. When deoxygenated, HGBS makes the red cells become rigid, sticky, and sickle-shaped.
And these sickled cells cause problems.
Big problems. They get stuck in small blood vessels, blocking flow. This causes severe pain episodes, vaso-occlusive crises, chronic anemia, organ damage, stroke, acute chest syndrome, like pneumonia, kidney disease, leg ulcers, jaundice, delayed growth.
What about thalassemia? Also inherited.
Yes, also autosomal recessive. Thalassemia involves missing or faulty genes needed to make the globin chains of hemoglobin itself. So you produce less hemoglobin and fewer healthy red blood cells. Two main types, alpha and beta, depending on which globin chain is affected.
Consequences.
Reduced hemoglobin leads to anemia. Defective red cells get destroyed in the marrow or spleen, sometimes forming Heinz bodies, clumps of damaged hemoglobin. The marrow tries to compensate, reticulocytosis. Chronic anemia can lead to bone changes like osteopenia or even facial deformities, chipmunk face, in severe forms. Symptoms are typical anemia symptoms: fatigue, weakness, pallor, jaundice.
Pernicious anemia, that's a B12 issue.
Yes, specifically vitamin B12 deficiency, usually caused by a lack of intrinsic factor. Intrinsic factor is made in the stomach and needed to absorb B12 from food. Without B12, red cell production, hematopoiesis, is impaired, leading to large, fragile red cells, megaloblastic anemia.
Does it affect anything else?
Critically, yes. B12 is also vital for myelin, the sheath around nerves. So deficiency causes neurological problems, tingling, numbness, walking difficulties, cognitive issues, memory loss. Treatment involves B12 injections or high-dose oral supplements, bypassing the absorption issue.
And iron deficiency anemia, very common.
Right, most common type globally. Caused by not enough iron intake, blood loss, like heavy periods or GI bleeding, or increased need, pregnancy, growth spurts. Iron is essential for the heme part of hemoglobin.
So low iron, low hemoglobin.
Right. Leads to smaller, paler red cells, microcytic hypochromic anemia. Body tries to compensate, but eventually you get tissue hypoxia. Symptoms: fatigue, weakness, shortness of breath, dizziness, pale skin, palpitations, tachycardia. Treatment involves finding and fixing the cause, plus iron supplements.
What about too many red blood cells? Polycythemia.
Right. Secondary polycythemia is an increase in red cells due to the body making more EPO, usually as a response to chronic hypoxia.
Like living at high altitude or lung disease.
Exactly. The body senses low oxygen and tries to compensate by making more oxygen carriers. The problem is too many red cells make the blood thick, viscous.
Harder for the heart to pump.
Yes, increases risk of clots, stroke, heart attack. Treatment focuses on the underlying cause of the hypoxia. Sometimes phlebotomy, removing blood, is needed to reduce the red cell count.
Okay, last blood topic. Clotting. Platelets, hemostasis, coagulation.
Crucial balance here: need to stop bleeding, but not clot too much. Platelets are the first responders, forming a temporary plug. Then the coagulation cascade kicks in a complex series of protein activations.
We monitor this with lab tests. PT, APTT.
Yes. Prothrombin time, PT, often reported as INR, International Normalized Ratio, measures the extrinsic and common pathways. It's used to monitor warfarin therapy. Prolonged PT-INR suggests issues with factors 7XV, prothrombin, or I, fibrinogen, or vitamin K deficiency, or liver disease.
And APTT.
Activated partial thromboplastin time measures the intrinsic and common pathways, used to monitor heparin therapy. Prolonged FTT points to issues with factors 12, 11, 9, XX, V2, or fibrinogen, or conditions like hemophilia, heparin use, severe liver disease.
Other tests.
Thrombin time TT checks the final step, converting fibrinogen to fibrin. D-dimer measures clot breakdown products. High levels suggest recent clotting activity, helpful for diagnosing DVT or PE. Fibrinogen level directly measures the amount of fibrinogen available.
So two starting pathways, intrinsic and extrinsic.
Right. Intrinsic starts with contact activation, like blood touching a damaged vessel surface, measured by FPTT. Extrinsic starts with tissue factor released from injured tissue, measured by PT-INR.
And they meet where?
Both pathways converge to activate factor X, turning it into factors N. That starts the common pathway.
What happens in the common pathway?
Factors N, along with factor V, calcium, and phospholipids, forms the prothrombinase complex. This complex converts prothrombin, factor 2, into thrombin, factor 2. Thrombin is key. It converts soluble fibrinogen, factor 1, into insoluble fibrin strands, forming the mesh of the clot. Thrombin also activates factor 13, which cross-links the fibrin, making the clot strong and stable.
The liver's role is big here.
Huge. The liver makes most of the clotting factors, including the vitamin K-dependent ones, 2, 7, 9X. It also makes natural anticoagulants and clears activated factors. So liver disease severely messes with clotting, usually increasing bleeding risk. That's why PT-INR is prolonged in liver disease.
Got it. Okay, let's breathe easier. Or maybe not. Let's move to the respiratory system.
All right. Lungs. Main job, well, get oxygen in, CO2 out. This involves ventilation, air movement, perfusion, blood flow through lung capillaries, and diffusion, gas exchange across the thin alveolar capillary membrane.
What can disrupt this? Like a blood clot, PE.
Pulmonary embolus, PE. A clot, usually from the legs, DVT, travels to the lungs, blocking a pulmonary artery. Disrupts perfusion. Symptoms often sudden. Shortness of breath, chest pain, maybe dizziness, rapid heart rate, can be life-threatening. Risk factors. Surgery, immobility, clotting disorders, cancer.
What about infections affecting breathing? Epiglottitis.
Epiglottitis is scary, especially in kids, though less common now due to vaccines. Bacterial infection causes the epiglottis, the flap covering the windpipe, to swell up rapidly. Severe sore throat, difficulty swallowing, drooling, high fever, and that high-pitched breathing sound, stridor. Airway closure is a major risk. Needs immediate hospital treatment.
Bronchitis.
Inflammation of the bronchi, the main airways, usually viral, sometimes bacterial, or due to irritants like smoke. Causes coughing with or without mucus, wheezing, chest tightness, fatigue. Acute bronchitis usually clears up. Chronic bronchitis is part of COPD. Pneumonia is an infection in the lung tissue itself. The alveoli fill with pus or fluid, caused by bacteria, viruses, or fungi. Symptoms: cough, often with phlegm. Fever, though elderly might not have fever. Chills, chest pain, shortness of breath, dyspnea. You might hear crackles when listening to the lungs. Risk of sepsis.
And there's hospital-acquired pneumonia.
HAP, yeah. Develops 48 hours after hospital admission. Often involves different nastier bugs like Staph aureus or MRSA. Patients on ventilators or with weakened immunity are at higher risk.
Tuberculosis TB, still a major issue globally.
Absolutely. Caused by Mycobacterium tuberculosis, spreads through airborne droplets, primarily affects lungs but can spread. Symptoms: persistent cough, 3+ weeks, chest pain, coughing up blood, hemoptysis, weakness, weight loss, fever, night sweats.
What happens in the lungs?
The immune system tries to wall off the bacteria, forming granulomas called tubercles. Sometimes the center necrosis, becoming cheesy caseous necrosis. This can show up on X-ray as a chine focus.
How's it diagnosed? That skin test.
The Mantoux test, or PPD. Inject protein derivative under the skin. A raised, hard bump in duration after 48-72 hours means exposure at some point.
Okay.
Doesn't tell you if it's active disease or latent TB. Bacteria dormant, no symptoms, not contagious. A positive test needs follow-up. Usually a chest X-ray, maybe sputum tests. The BCG vaccine can cause a false positive.
Treatment.
Active TB requires a long course of multiple antibiotics, often 6 months or more, to prevent resistance. Isolation is needed initially for contagious patients. Latent TB is also often treated with antibiotics to prevent it from becoming active later.
Okay. You mentioned obstructive versus restrictive lung diseases earlier. Can you explain that again?
Sure. Think of breathing through straws. Obstructive is like breathing through a narrow, floppy, or mucus-filled straw. Air gets in okay, but it's hard to get it out. Air trapping, examples: COPD, asthma, bronchoconstriction, airway tightening makes it worse. Bronchodilation, relaxing airway muscles helps. Restrictive is like breathing through a very narrow, stiff straw that won't expand. You can't get a full breath in. The lungs themselves are stiff or can't expand fully. Total lung capacity is reduced. Examples: pulmonary fibrosis, scarring, scoliosis affected the chest wall, neuromuscular diseases, weakening breathing muscles.
Let's talk COPD specifically.
Chronic obstructive pulmonary disease usually includes chronic bronchitis, airway inflammation, mucus, and emphysema, damage to alveoli, overwhelmingly caused by smoking, but air pollution, genetics play a role. Main symptom: progressive shortness of breath, especially with exertion. Also chronic cough, wheezing, fatigue. It's obstructive, hard to exhale fully.
Diagnosis. Treatment.
Spirometry is key for diagnosis. Shows reduced FEV1 and FE1-FVC ratio. Hallmark obstruction. Imaging, X-ray CT helps. Treatment involves stopping smoking, crucial. Bronchodilators, inhalers to open airways, inhaled steroids, reduce inflammation, oxygen therapy if needed, pulmonary rehab. No cure. Focus is managing symptoms, slowing progression.
Asthma, also obstructive.
Yes, but it's typically episodic. Airways become inflamed and hypersensitive to triggers: allergens, cold air, exercise, infections. Leads to bronchoconstriction, swelling, mucus. Symptoms: wheezing, shortness of breath, chest tightness, cough. Often reversible with treatment or spontaneously.
Diagnosis and treatment for asthma?
Spirometry, often showing reversible obstruction after bronchodilator. Allergy testing to identify triggers. Treatment involves avoiding triggers, using quick-relief rescue inhalers and bronchodilators like albuterol for attacks, and daily controller inhalers, usually inhaled corticosteroids, to prevent inflammation.
What about a collapsed lung? Tension pneumothorax.
Pneumothorax is air in the space between the lung and chest wall. A tension pneumothorax is when air gets in but can't get out, like a one-way valve. Pressure builds, collapses the lung, and can push the heart and major vessels to the other side, compromising circulation. Life-threatening emergency.
Causes.
Often trauma, but can happen spontaneously. Symptoms: sudden, sharp chest pain, severe shortness of breath, rapid heart rate, low blood pressure, maybe tracheal deviation, windpipe shifts away from affected side. Needs immediate decompression with a needle, then a chest tube.
Pulmonary hypertension, high blood pressure in the lungs.
Exactly. The arteries in the lungs become narrowed, stiff, or damaged. Harder for the right side of the heart to pump blood through them. Leads to right heart strain and failure eventually. Symptoms: shortness of breath, especially with activity, fatigue, dizziness, chest pain, swelling in legs, abdomen. Can be idiopathic or related to other conditions: lung disease, heart disease, clots.
Diagnosis. treatment?
Echocardiogram can suggest it.
Yeah.
Right heart catheterization confirms diagnosis and severity. Treatment involves medications to relax, dilate pulmonary arteries, oxygen diuretics, lung transplants in severe cases.
And we mentioned pulmonary embolism again, big one.
Yes, PE, clot-blocking lung artery, sudden onset shortness of breath, sharp chest pain, often worse on inspiration, maybe cough, sometimes with blood, rapid heart rate, anxiety. Diagnosis often uses CT pulmonary angiography, D-dimer blood test, rules it out if negative, but not specific if positive. Treatment involves anticoagulants, blood thinners, to prevent more clots, sometimes thrombolytics, clot busters, or procedures to remove large clots.
How do we definitively tell obstructive versus restrictive PFTs?
Pulmonary function tests, especially spirometry, are key. Remember, FEV1, forced expiratory volume in 1 second, and FEC, forced vital capacity total exhaled. The FEV1-FEC ratio is crucial. Low ratio, 70% usually, indicates obstruction can't get air out quickly. Normal or high ratio suggests restriction. Both FEV1 and FEC are reduced, but proportionally.
What about arterial blood gases, ABGs?
ABGs give a snapshot of gas exchange and acid-base balance, measure pH of acidity, PaSO2, carbon dioxide, PO2, oxygen, and HCO3 bicarbonate. Normal pH is tightly controlled, 7.35, 7.45, PaSO2, 35, 45 mmHg, HCO3, 2226 MEQL.
Acidosis versus alkalosis.
Low pH, 7.35, is acidosis, too much acid. High pH, 7.45, is alkalosis, too little acid, too much base. If the problem is CO2, it's respiratory. If it's bicarbonate, it's metabolic.
How does this relate to lung disease?
In obstructive diseases like severe COPD, patients often can't blow off CO2 effectively. CO2 builds up, acts as an acid in the home, respiratory acidosis, low pH, high PaCO2. In restrictive disease, CO2 might be normal initially, but severe restriction can lead to hypoxia, low PO2, and eventually respiratory failure.
So reading an ABG involves steps.
Yeah, a simple approach. 1, look at the pH, acidosis, alkalosis, or normal. 2, look at PaO2, is it causing the pH change? High CO2 equals respiratory acidosis, low CO2 equals metabolic alkalosis. 3, look at HCO3, is it causing the pH change? Low HCO3 is the other system trying to fix the pH. 5, check the PO2 for hypoxia.
Okay, final section. The brain and nervous system challenges. Starting with blood vessel issues there, cerebrovascular.
Right, strokes are the big one here. 2 main types. Ischemic stroke is the most common, about 85%. Exactly.
Huh?
A clot, thrombus forming locally, or embolus traveling from elsewhere, often the heart, blocks an artery in the brain. No blood flow, no oxygen, brain cells start to die, infarction.
Symptoms, fast.
Yes, fast is key for recognizing it quickly. Face drooping, arm weakness, speech difficulty, time to call 911, time is critical.
Treatment.
If caught early, within about 4.5 hours, clot-busting drugs like TPA can be given. Sometimes mechanical thrombectomy, physically removing the clot, is possible for large clots. Then antiplatelets or anticoagulants to prevent recurrence.
And the other type, hemorrhagic.
Hemorrhagic stroke is less common, 15%, but often more deadly. A blood vessel ruptures in the brain. Bleeding occurs directly into or around brain tissue.
Causes, symptoms.
Often due to chronic high blood pressure weakening arteries or a ruptured aneurysm, a bulge in a vessel wall. Symptoms often include a sudden severe headache, worst headache of my life, nausea, vomiting, sometimes seizures, loss of consciousness. Treatment involves controlling blood pressure, possibly surgery to stop the bleeding or relieve pressure.
What about TIAs, mini strokes?
Transient ischemic attack. The term mini stroke isn't quite accurate because there's no permanent damage, but it's caused by a temporary blockage. Stroke-like symptoms appear but resolve completely, usually within minutes to hours, definitely less than 24.
So no big deal.
No, it's a huge raised warning sign. High risk of a full stroke soon after. Needs urgent evaluation and treatment to manage risk factors, aspirin, statins, blood pressure control, lifestyle changes.
You mentioned Cushing's triad earlier.
Yeah.
Relevant here.
Yes, it's a sign of critically high pressure inside the skull, often pressing on the brainstem. Ominous sign. 3 components: hypertension, high blood pressure, often widening pulse pressure, bradycardia, slow heart rate, and irregular respirations. Slowed, abnormal pattern. Means the brain is struggling badly.
In an ischemic stroke, what's the penumbra?
Okay, picture the blocked artery. Right around it is the core infarct tissue that's already dead or irreversibly damaged. But surrounding that is an area called the ischemic penumbra.
What's special about it?
Cells in the penumbra are injured, not getting enough blood, but they're still alive. They're salvageable if blood flow is restored quickly. That's the target for acute stroke treatment, save the penumbra.
And brain herniation.
That's when increased intracranial pressure, ICP, physically pushes brain tissue out of its normal compartment, maybe down through the opening at the base of the skull, compressing the brainstem. Devastating. Causes: severe swelling, large bleed, tumor. Signs: headache, vomiting, altered consciousness, unequal pupils, blown pupil, Cushing's triad, posturing, respiratory arrest. Needs immediate action to lower ICP. Meds like mannitol, surgery.
Okay, let's quickly summarize those.
Ischemic stroke, blockage, cell death. Penumbra, at risk but salvageable area. Brain herniation, brain squeezed out of place by pressure, often fatal.
Got it, got it. Now, what about chronic degenerative neurological conditions?
These progress over time. Parkinson's disease, loss of dopamine-producing cells in the basal ganglia, leads to tremor, often starting as pill rolling, rigidity, stiffness, akinesia, bradykinesia, lack of slowness of movement, postural instability, balance problems, shuffling gait, masked face, small handwriting too. Treatment aims to boost dopamine, levodopa agonists.
Myasthenia gravis, autoimmune.
Yes, autoimmune attack on acetylcholine receptors at the neuromuscular junction. Muscle weakness that worsens with activity, improves with rest, often affects eyes first, ptosis, drooping eyelids, diplopia, double vision, then facial muscles, swallowing dysphagia, speaking dysarthria, limbs. Treatment: acetylcholinesterase inhibitors, boost acetylcholine signal. Immunosuppressants:
ALS, Lou Gehrig's.
amyotrophic lateral sclerosis, degeneration of motor neurons in brain and spinal cord, progressive muscle weakness, atrophy, twitching, fasciculations, cramps, starts in limbs usually, affects speaking, swallowing, and eventually breathing. Sensory and cognitive function usually is spared until late, cause unclear, maybe glutamate excitotoxicity. Treatment: riluzole edaravone, offers modest slowing, relentlessly progressive.
Multiple sclerosis, MS, also autoimmune.
Yes, autoimmune attack on myelin, the insulation around nerve fibers in the brain and spinal cord, leads to inflammation and scarring. Sclerosis, disrupting nerve signals. Symptoms vary wildly depending on where lesions occur. Numbness, tingling, weakness, vision problems, optic neuritis, balance issues, fatigue, often worsened by heat, cognitive changes, pain. Relapsing remitting is common pattern. Treatment: disease-modifying therapies, DMTs to reduce relapses, steroids for acute flares, symptom management.
And for all these, basic ABCs are critical if they worsen.
Airway, breathing, circulation. Absolutely vital if someone with these conditions has an acute crisis like respiratory distress and late ALS or MG.
Let's touch on seizures.
Seizures are sudden surges of abnormal electrical activity in the brain. Can manifest in many ways. Phases include possible aura, warning sign, ictal phase, the seizure itself, postictal phase, recovery, often tired, confused, headache, amnesia. Interictal is the time between seizures.
Diagnosis.
History is key. Blood tests, CBC, electrolytes, glucose, brain imaging, MRI usually preferred over CT, EEG, electroencephalogram, records brain waves, often done sleep-deprived, to increase chance of catching abnormalities.
What about status epilepticus?
Medical emergency, defined as a continuous seizure lasting 5 minutes or 2 or more seizures without full recovery of consciousness between them. Can cause permanent brain damage or death. Needs immediate treatment. Manage ABCs, give IV benzodiazepines like lorazepam or diazepam to stop the seizure quickly, then figure out the underlying cause.
Okay, last area, brain and spinal cord injury.
Spinal cord injury, SCI, can be from primary trauma, impact, fracture, and secondary injury processes that follow: inflammation, swelling, ischemia, bleeding within the cord.
Symptoms depend on the level.
Yes. Injury level determines what functions are lost below that point. Paralysis, quadriplegia, tetraplegia, or paraplegia, sensory loss, bowel bladder dysfunction. High cervical injuries, C1, C4, affect breathing muscles. Autonomic dysreflexia, dangerous blood pressure spikes, can occur in injuries above T6. Imaging: CT for bone, MRI for cord soft tissues.
Failure skull fracture, fracture at the skull base.
Right, often from major trauma. Signs can be subtle or dramatic. Battle sign, bruising behind ear, raccoon eyes, bruising around eyes, CSF leak, clear fluid from nose ear test for glucose yellow sign, hearing loss, facial nerve palsy, vision changes. CT is best for seeing the fracture. High risk of meningitis if CSF leaks.
Increased intracranial pressure, ICP, we mentioned this.
Pressure inside the rigid skull. Increases with swelling, edema, bleeding, hematoma, or a mass tumor. Dangerous because it can compress brain tissue and reduce blood flow, leading to herniation.
Symptoms.
Headache, often worse in AM with coughing. Nausea, vomiting, altered consciousness, lethargy to coma, pupillary changes, sluggish, unequal, fixetilated, Cushing's triad, late ominous sign, seizures, vocal deficits. Diagnosis: CT-MRI, can be monitored directly with an ICP monitor inserted into the brain.
How do we assess consciousness level quickly? GCS.
Glasgow Coma Scale, standardized score based on eye opening, score 1 to 4, verbal response 1 to 5, and motor response 1 to 6. Total score ranges from 3, deep coma death, to 15, fully alert. Quick way to track changes.
Finally, bleeding in the head, Subdural versus epidural hematoma.
Location is key. Subdural hematoma, bleeding under the dura, between dura and arachnoid mater, usually from tearing of bridging veins, often slower onset, especially in elderly or alcoholics. Chronic subdural. Symptoms can be vague: headache, confusion, drowsiness. Crescent shape on CT MRI. May need surgery if large symptomatic.
And epidural.
Epidural hematoma, bleeding above the dura, between dura and skull, usually caused by skull fracture, often temporal bone, tearing an artery, middle meningeal artery. Arterial bleed faster, higher pressure. Classic story, not always present, is brief loss of consciousness, then a lucid interval, then rapid decline. Lens shape, lenticular on CT. Surgical emergency needs rapid evacuation.
Okay, quick summary table in our heads. SEI, core damage, level dictates deficit. Basilar fracture, skull base, look for specific signs. Increased ICP, pressure danger, watch LSE pupils Cushing's. GCS, consciousness score. Subdural, venous, slower crescent. Epidural, arterial, faster lens.
You got it. Covers the main points.
Wow, this has been an incredibly thorough deep dive. It really highlights how everything in the body is connected, doesn't it? From that first spark of inflammation.
All the way through the immune response, how blood cells function or malfunction, how the lungs work, and what happens when the brain structure or function is challenged. It's intricate.
Any particular aha moments or surprising facts for you looking back over this?
I always find the fundamental purpose of inflammation is repair quite striking, because we often just think of it negatively. Also, the sheer specificity in different jobs of all the white blood cells is amazing. And that concept of the ischemic penumbra, that window of opportunity in stroke, is so critical.
Absolutely. And hopefully, for you listening, this gives you a much stronger foundation for understanding these really vital, sometimes complex bodily processes.
Definitely. And maybe it leaves you with a final thought to chew on. Considering everything we've talked about, inflammation, immunity, blood health, lung function, brain health, how might your everyday choices, diet, exercise,
Yeah.
smoking or not smoking, how might those lifestyle factors directly impact these fundamental processes and, in turn, influence your risk for some of the conditions we discussed or how they might progress?
Something to think about, and maybe explore further if any particular area sparked your interest today. Thanks for joining us on the Deep Dive.